All right, let's talk real quick about cardiac arrest management. What matters, what doesn't really matter. How do we get to ROSC, return of spontaneous circulation? What happens then? And how does the team work together? So the key foundational concept that we're going to hammer over and over and over in this and every other training that we do is that high quality CPR matters. It matters most, and it's almost the only thing that matters. Early defib's important, ALS meds are important, but really CPR quality, high quality CPR is what is clearly the goal and what we're trying to get done here. So what is high quality CPR? Well, there's two parts to it, and we talk a lot about compression rate between 100 and 120, no slower, no faster. Correct depth, which is most easily measured by a chest depth proportion, so you need to compress at least a third to half the way down. That probably equates to about 2 inches or a little more in most adults, but really the 1/3 to 1/2 chest depth is the best way to tell. And then full recoil, so rate, depth, and full recoil. The other part of high quality CPR is limited interruptions. And because blood flow stops immediately when compressions stop, and it takes several compressions to get us back to where we were, which wasn't all that good to start with. And so blood flow, good blood flow is needed in order to perfuse, get circulation, get oxygen to that myocardium in order for us to get them to come out of VFib and stay out of VFib. In order to get them out of asystole, in order to get ROSC, we need good blood flow, which comes from great compressions and limited interruptions. CPR feedback helps us do great compressions. Our new AEDs have excellent feedback. They have a rate feedback mechanism via the metronome, and then there'll be voice prompts and text messages on the AED screen talking about depth. It says push harder. What we mean is really push deeper. And then it also gives you some indication of full recoil via a graphic indicator. Then when the ALS crew gets there, the Zoll X series monitors give us excellent feedback as well with some graphical representation, as you can see there with the bars in terms of depth as well as numerical representation. Feedback matters. If you've used feedback to help you with your CPR, I think you would agree that it makes better CPR. Team members can also give some CPR feedback, and so this whole pit crew concept is very popular jargon to throw around, but what it means really is that each individual is filling one role and doing one thing, but let's figure out what those things should be. So from playing with this a little bit and practicing in a lab setting, we've found that the chest person, the person doing chest compressions, needs to listen to the metronome, listen to the rate, just worry about rate. If they try to look at the depth and full recoil indicators, it becomes too confusing. It's very easy to lose your rate because you're working on the other two. So chest guy focuses on rate. Then there's some verbal feedback that can come on depth and full recoil, both from the monitor and from another person there called the mask person. Mask person is at the head, is handling jaw thrust, managing the airway, and is really in the best position to watch the AED or the ALS monitor, coach the chest person, say things like good, doing good, or go deeper, or full recoil. And so the chest person listens to the rate and focuses on that. And then with their other ear, so to speak, they can hear some fine-tuning on depth and full recoil. The third member of the pit crew is called BAG. That person counts compressions. That person deals with ventilations and counts compressions. The chest person, if they're trying to count as well as do rate, as well as do depth, as well as do recoil, it's too much and performance degrades. So this is what we're recommending as the best practice. So we talked about rate and depth and full recoil as a high quality compression, and the other part of high quality CPR is how to limit interruptions. One of the best ways to limit interruptions is to get rid of, as soon as you can, the most common interruption. If we don't have an advanced airway in place, meaning a King or an intratracheal tube, ET tube, if we don't have an advanced airway in place, we have to do 30-2. If we can get an advanced airway in place, we can simply do continuous compressions and breathe once every 6-7 seconds. Another way to limit interruptions is to make a smooth switch on the chest. So if we don't have an advanced airway in place, or even if we do, during that pause where the AED is analyzing, or in the ALS Crews case, when they're doing charge and check and they're analyzing, that's when the switch needs to happen. So the person that's going to take over compressions needs to get immediately into place and be ready to go as soon as the shock is delivered. Once we deliver a shock, we do compressions every single time. So as soon as that shock is delivered, the compression person should come right down and start CPR, start compressions. Our mask person can coach and call the plays. The mask person should be focused on high quality compressions and limiting interruptions. And then the last thing is for the medics, we are not going to pause compressions to intubate. If you can't intubate with compressions going on, then don't intubate. The value of the ET tube over another airway is not worth it to put up with the interruption. What about breathing? Well, in the first few minutes, high quality CPR is really important. Uninterrupted compressions are king. If you've got personnel to do ventilations, that's great. If not, just focus on compressions. And we'll talk more about this on how it looks like in a few minutes. But after about 4 minutes, you're going to need to deal with ventilations as well. So early on, let's really emphasize compressions, do ventilations if we can. And as soon as we can, let's get real ventilations going as well. What do you use for ventilation? Well, if you're by yourself, pocket mask. If you've got a second person, you should use the bag valve mask. You should never use the bag valve mask by yourself. One person BVM is clearly not the standard by anybody's measure. If you've got two people, one can be chest and one can be mask. And the chest person can do 30 compressions and then reach over and squeeze the bag. The mask person stays put. If you've got a third person, then let them take over the bag role. What about airway? Well, right off the bat, pocket mask, bag valve mask with good jaw thrust and OPA and MPA, that's adequate initially. And then let's move as quickly as we can to a supraglottic airway. On the fire district's case, it'll be a king, but there's all the supraglottics SGA listed there. Why is that a big deal? It's not about the airway. It's about it allows us to go to continuous compressions. Yeah, we get some side benefit and maybe a little less gastric distension when you go early to that king airway, but we're not making a change to early supraglottics based on airway. We're making it based on the need to get rid of interruptions. What about an endotracheal tube? Well, that's great. An endotracheal tube is a wonderful thing, but if there's already a working SGA in place, then leave the king. Don't interrupt compressions to do an intubation, and don't replace a good supraglottic just so you can have an ET tube. During the arrest, it's all about not interrupting compressions. So the early use of the SGA, well, if we got a two-person crew, and assuming that there's an EMT involved in that, early insertion of the king allows us to go to continuous compressions, fewer gastric distension, and we switch to the bag and chest person roles. And then if you have a three-person crew where you've really got it made, compressions happen continuously. We can get that SGA in quickly, the king in quickly, which allows the compressions to go continuously. And we can deal with that gastric distension a little better and free up that third person to do the other multiple roles. We've had really good anecdotal success around here with mechanical CPR devices over the last 7 or 8, 9 years. Really good anecdotal evidence. On a national and international basis, there's been large studies that show that the mechanical CPR device is equivalent to good manual CPR as long as you're stationary. The mechanical devices really shine during movement because manual CPR during movement and transport really is not a very good process. But the auto pulse in our case here locally is a good thing if our folks are tired, if the manual compressors are worn out, or if we're going to be on the move. But there is an interruption to place that, and we're really trying to limit all these interruptions, particularly in the first 5 to 10 minutes, take all the interruptions out. So probably best plan, hold off till about that 5-minute mark when you've already got some things going on and you have meds on board and things are moving along. You're starting to prep for ROSC. You're thinking about what's going on. Unless your manual compressors are worn out already, maybe there's a long response time for the ALS unit and your manual folks are already worn out, then move to it earlier. But let's hold off for the first several minutes until you get to that point where you're starting to think and get some other things under control, and then move to that. Mechanical CPR device would be excellent to be on the cart as we get ready for ROSC. Remember, this whole thing is about ROSC. ROSC is the goal. We expect to get return of spontaneous circulation. We need to prepare for what's going to happen when we get there, and we need to be watching for that. And so it's not just that we recognize ROSC at a charge and check, at a pulse check time. You'll see a spike in their end-tidal CO2 and their capnography when they get ROSC. If it's possible to see through CPR, where there is software available for both AEDs and monitors, if it's possible that you can see what the rhythm is underneath the CPR, that's great. You may be able to anticipate a change. You can at least see a change in rhythm. And then ROSC is unfortunately frequently a temporary thing, and they do rearrest. How do we prep for it? Well, we have a code reference card that we give out in our paramedic program. There's a blue area on there. So at the point where the team leader has gotten meds on board, has assigned the airway, and is now ready to think, the first thing we're going to think about is prepping for ROSC. Secondly, run through a quick checklist on what to do when you get ROSC, and then start thinking about causes. So we have a card that has those things on both sides. And the blue area on the code reference card talks about get the ambulance cart close to the patient, get a mechanical CPR device on the cart unless it's already on the patient, because we're going to go. We're going to transport. We're going to be on the move when we get ROSC. And CPR on the move needs to be done with mechanical device. We need somebody to figure out our route out of the house. The way we came into the patient may have been the quickest, easiest way, but moving a patient out on a cart may not be the easiest way. Need to get the ambulance ready, turned around if necessary, backed out of the drive, whatever. Identify who's going to drive, identify who's going to go in the back, how we're going to deal with that. We need to get demographics on the patient. The team leader will probably know a great deal about the patient's last few minutes, but may not know their name, their date of birth, last four of their social. We need to get that information so the patient can be registered and old medical records can be accessed on that patient at the hospital. And then someone needs to help the family. Someone definitely needs to help the family. Preferably someone who can explain what's going on and then offer assistance. And we want to think about how they're going to get to the hospital and all those safety things and just that good helping hand sort of service that we need to do for those folks. Now, when ROSC happens, because we expect it to happen, when it happens, we're going to tie everything down, check everything out, hook everything up, get on the road, get on the phone. Tie everything down means make sure your airway is secured. C-collars are excellent to limit head movement. It has nothing to do with spinal motion restriction. It has to do with head movement restriction. And let's secure those IVs and IOs, and we're going to be talking about humeral head IOs a lot more here in a minute, and locally it's going to become the way. And let's be very careful about dislodging those. We're pretty much used to working with the tibial IOs, but the humeral heads we aren't used to working with, and so let's be extra vigilant that we don't dislodge one of those. Check everything out, make sure your O2 tank hasn't run dry, your IV fluid hasn't run dry. Hook everything up, and usually you walk in on a code as the paramedic team leader and the patient wasn't on pulse ox or non-invasive blood pressure before they coded, so now you need those. In ROSC, you need all the data you can get, and the BP is one of the most important ones. And then get on the road. This is now definitely a time-critical diagnosis. And then get on the phone. At least let the ER know you're coming, and then you're probably going to need to consult with online medical control. So what's the ALS sequence look like? Well, first thing medics do when they walk in the door is make sure we're doing good CPR. And then pause briefly for a pulse check to make sure the patient doesn't actually have a pulse and doesn't need CPR. And then that usually is a short, quick check, and we go right back to compressions. We trade out the switch cables, so trade out the AED for the ALS monitor. And while that's happening, we're talking about, is there one of the four reasons why we should not be doing CPR? Is the patient got rigor? Does the patient have venous pooling, dependent lividity? Does the patient have an obviously mortal wound? Does the patient have a valid out-of-hospital DNR request? But as soon as those pads are hooked up, we need to charge up and then hand on femoral pulse and pause CPR for a very brief time and figure out what that EKG is, if that is a shockable or not shockable EKG. If it is shockable, we say shocking on 3, 1, 2, shock, and start CPR. If it is not shockable, we say no shock, and then we think about the pulse to decide if we're going to do CPR or not. So this charge, check, act thing can be done reliably in 5 seconds or less. We've tested this with paramedic students who are still novices at this, and they can do it in 5 seconds or less, and then some of us that have some experience can get it down in the 2 to 3 second range. So a dramatically fast time there on that charge and check and analysis is what we're looking for. So as soon as that initial charge and check and action has happened, the very next thing is get meds. It's not get an airway, it's get meds. We need to get medication route and give some epi. Epi supports CPR. We need to get the epi going, and then we need to get ready for an antiarrhythmic, whether it's amiodarone or lidocaine, and get those ready. In some services, those have to be drawn up. In other services, they come preloaded. And so the team leader's thinking about that next medicine, not the first medicine. Epi's obvious. It's the second medicine that they're prepping for. That'll probably take them a full 2-minute cycle, so they're going to charge, check, and act again. Give any meds that are needed right after that shock. If they did shock, they'll give one of the antiarrhythmics. If they did not shock, they won't. Then they're going to be where they consider the airway. And we're really going to kind of push here that if you're double medic, then send another medic up to the airway and assign that to them. If you're split crew, send your partner, your EMT up there, and let them put a supraglottic in and be done with it. Then we're going to think about getting ready for ROSC, which we talked about briefly with the do the blue on the ROSC, on the cardiac arrest checklist, do the blue area, do all those things to get ready for ROSC, and then start thinking about the causes, the old H's and T's and everything else, and take action as needed. So that's what the medics are thinking, what the ALS sequence is going on. So what about meds? Well, epi probably helps. It probably doesn't hurt, although there's some thought down the road that we may be replacing epi with a beta blocker, quite the opposite of epi. But right now, the science and the opinions are that it makes CPR better, and that is via its vasoconstriction effect. It might help a little bit with its beta-1, chronotropin, inotropin, asystole. It might help some in PEA, particularly with the inotropy, because that pulseless electrical activity is possibly a pulse you can't feel electrical activity. And again, it's unclear if it's really helping in VF. It might even be hurting in the shockable rhythms, and there might be some esmolol or some beta blockers down the road. Cardiac arrest management in terms of pharmacology changes and has changed many times and will change more going forward. The other meds in a code are the antiarrhythmics, amiodarone or lidocaine. They possibly help. Neither of them have proven to change survival outcomes, and both are about equally weak, so it's kind of dealer's choice right now. But epi appears to still be something that we're going to be dealing with. So what route do you use? Well, the humeral head IO is pretty fast to initiate as long as you understand the landmarks and are competent there. You can get meds in extremely fast in a matter of just 4 or 5 seconds from that site, and you can give large volumes of fluid if you need. Peripheral IVs are probably second. Those may be fast to initiate, or they might not. If there's a good, obvious peripheral IV, then go for it. And usually that's going to be an AC. Those meds get in pretty quickly enough, and you could give some volume if you needed to. And then the old tibial IO, which has really been popular around here in the last 8-9 years. It's quick and fast to initiate, easy landmarks, haven't had a lot of problems with it being dislodged. But recent evidence is that the meds take maybe as long as 3 minutes to get from there to the heart, and so that's not the optimal situation. And some of those will flow decent volume, others won't. You don't know until you try it. But basically, humeral IO is looking like our first choice unless there's a great big easy-to-hit AC. If you can't do humeral head IO is not an option, go for that peripheral IV. But if you're going to have a lot of trouble and spend a bunch of time, then let's get the tibial IO and then start looking for a peripheral IV later. Not a bad idea to have a backup in any case, so that peripheral IV probably wouldn't be a bad plan, regardless of which IO site you end up using. What about external jugulars? Well, a long time ago, they were pretty popular. They're probably not as easy, maybe some more complications. There's nothing wrong with them. And then remember that C-collar that you're going to use to limit your head movement is really going to conflict with that EJ. Now you're thinking about causes. So we're talking about the H's and T's reference card. And you know what? You ought to use reference cards for this stuff. The patients really don't care if we can memorize stuff. They just need us to get it right. Hypothermia is one of the H's. It's going to be managed differently. Most protocols will limit the shocks and limit the medications. And then tamponade is not going to get fixed in the field if for some reason you can somehow tell that tamponade is what the cause is. Certainly a lack of a femoral pulse with good CPR, according to ACLS, lets you know that it is tamponade, but we still have a heck of a time fixing that in the field. So bottom line about the H's and T's and the causes is whatever caused that code probably wasn't fixed during that code. ROSC is great, but probably half the time the patient slips back out of ROSC. A couple of comments about pads and pad placement. I think what we've moved to here locally finally is the ability to have the BLS folks applying the set of pads that are going to be used by the ALS folks. So there's no swapping of pads during the critical first minutes of a cardiac arrest. Anterior posterior is okay, anterior lateral is okay. The ones that we're going to be using with the CPR feedback device on them, the puck, so to speak, anterior lateral is the only place to go, so that's all right. If the medics want to pace and really think AP is going to be better for them, they can put on their own second set of pads, that's fine. If your patients receive multiple shocks, so some from the fire department, some from the medics, as the team leader, if you're into this multiple shock, and I don't really have a good number for that, it's at least 5 or more, then maybe you consider changing pad placement. Maybe that vector change on the shock will do some good. And so if you don't have AP, that might be another time to try AP. It could also be, probably more likely, that your CPR is just not getting a diastolic pressure high enough to perfuse the coronaries, and the patient's not going to shock out because they just aren't being perfused. So what about the team here trying to come to a conclusion here on this little screencast? I think in our system, we need to look at BLS crews that come in as a 1-person, a 2-person, a 3-person, and then ALS crews that are double medic and those that are split. So in the BLS PIC crew roles, we talked about already, the chest person handles compressions. They are focused on the rate. The bag person takes care of counting and gives ventilations after 30 compressions until we have an advanced airway in place, in which case they ventilate once every 6 or 7 seconds. I think we're going to see the use of timing lights on the bag valve mask to help us with that counting. Mask person's going to handle airway with a jaw thrust, mask seal, and they're in pretty good position to coach the chest person on depth and recoil, as well as to lead that BLS team. And then once that supraglottic's in place, then we drop one of those folks out, and the bag person takes over pretty much all of that coaching and counting stuff. BLS code sequence AED is great if you have it when you first walk in. Turn it on and then place the pads. It has a relatively short but not insignificant boot up time. So turn it on. Previous AEDs would turn on when you flip the lid open, but these AEDs have, the new ones that we are implementing, have an on button up in the top right, very obvious on button. Turn that on and place your pads and then do what the AED tells you to do. Once it's on, it will say assessing or analyzing, and it wants you to stay clear. And so what you should do then is use that time to get in your bag. Get some O2 out, open up the top of the bag and get the bag valve mask compartments and the King Airway, get those out. So dig in your bag, don't stare at the AED. It will tell you what to do, and it will take a few seconds to charge up, as much as close to 20 seconds possibly here. You're going to have some time to get some stuff out. And then compressions. After every shock, there's no pulse check. If we just shocked, then we're compressing. If we didn't just shock, then we're looking for a pulse. And the AED will prompt you to do compressions if no pulse. So there are two situations. It could be a non-shockable ECG. The heart rhythm could be flatline, or something else, but it doesn't have a pulse. Either way, we're doing CPR. It could also be ROSC. They could be in a rhythm and they could have return of spontaneous circulation. BLS Crews, we need to talk about what to do when a 3-person, 2-person, 1 person with the stuff, and 1 person by themselves as in a POV response. So 3-person, it's easy. One of you's chest, one of you's mask, one of you's bag. The bag person can place that SGA. If it's 2-person, we can still use a bag valve mask. The chest person will squeeze the chest and then squeeze the bag, and mask will do their usual thing. If you're by yourself, but you have equipment, you have the EMS pack and AED, we're going to do compressions only for 4 minutes before we switch to pocket mask in 30 to 2. So you turn the AED on, you attach the pads, you dig stuff out of your bag to get ready for that 4-minute mark, and then after 2 minutes the AED will have you analyze, and you act and just do compressions during that time, and then after another 2 minutes the AED will have you analyze, and it's after that point that you're going to have to do pocket mask unless you've got some more help. The exception to this across the board is on pediatrics, and that's defined as 8 years old and younger. So if you're working somebody that's 8 and younger, so that's 2nd grade and below, we're going to go with pocket mask in 30 to 2 from the start. It's not compressions only in pediatrics, the assumption being that it's more likely a respiratory cause. The other caveat would be if you absolutely know somehow that this patient was a respiratory patient, a hypoxic patient before they arrested, and you wanted to add ventilations in there, that would be acceptable. Now, what if you come in and you're by yourself in your car, all you have is pocket mask, you got there really quick, apparatus is not there yet, but presumably on the way. So what do? Well, you do compressions only. So it's the same thing as you would do if you had all the stuff, you just don't have all the stuff. So all you can do is compressions only for 4 minutes and then start using your pocket mask. ALS Crews, well, those come in 2 flavors. They come in double paramedic and sometimes multiple ALS providers. In the situation where there's several medics around, they may have a medic student on their truck. There may be a supervisor, maybe a second medic unit. There may even be medics on the fire department that are able to do ALS things. So if you've got double medic or multiple providers, one of them needs to be the leader. That person does monitor and meds. Then the partner or partners are going to help that leader get the meds on board, and then one of them can go deal with airway. And then once airway is handled, those partners can do all kinds of things. They can consult and cross-check during the thinking phase with the team leader. They can certainly handle prep for ROSC. They can do great stuff for family support. Use those medics as best you can. Sometimes the medic unit will come in as a split crew, meaning 1 EMT and 1 paramedic. So it's the same as above. Same route. They're going to help the team leader get meds on board, and then for airway, hey, why not let the EMT on the ambulance do the airway? You can also assign them to prep for ROSC, and unless the FD can manage, and I really would hope that our fire department can manage those prep for ROSC things quite effectively. So takeaways to wrap this up. Compressions are king. That's what matters the most. CPR feedback helps you do good compressions. Interruptions and compressions are bad. Advanced airways help us go to continuous compressions and eliminate the most common interruption at the old 30 to 2, give them 2 ventilations. That paramedic team leader needs to get in there and get that charge and check done, take their initial action, get some epi on board, assign that airway, and then start thinking. There's time to think, but there's time to do. It's a time to do in the first 3 or 4 minutes. And I really, really hope that we as the BLS fire department folks, we own that CPR. Let's don't make the medics have to be coaching us on CPR. Let's own CPR. And then I think when we put all this together, we're going to see a change. We're going to see an improvement in cardiac arrest outcomes.